we start, I request our chairman, Dr. Naran Hebsur, to welcome the gathering.
Thank you, Chandru. I bring a very warm welcome to all of you for this journal club. We are continuing the scientific journey, and the Director of Academics of ASI, Dr. Siddesh sir, and past President Siddesh sir is already come in right time. Welcome, sir. I welcome the National EC member, Dr. Shanai, and other I think so I'm seeing, and other state EC members also. I request Dr. Ravishankar to please start with the journal club.
Thank you very much, Hebsur sir. At the outset, I would like to thank and place on record my deep gratitude to KSCASI for reposing their faith and asking me to moderate this session. I also thank the two speakers, Dr. Niranjan and Dr. Nishant, for their role in this journal club. As you all know, change is the only constant in life, and the surgery is changing so rapidly. I think the students will find it difficult as to how to adapt to the change. The adaptation to change has to be based on sound scientific principles and precise data, which would then strengthen their conviction as to why they should change their current method, because things keep changing. And as we all know, there are many methods of study. And for example, there are subject seminars, there are morbidity and mortality meeting, reward rounds, invited guest lectures, specialty lectures by the faculty, and journal club. And most of the time, I would presume that most teaching institutions will have journal club once a month. And each of these things that I have enumerated will serve a specific purpose. And the purpose of journal club is to two things. One is the critical appraisal of the literature. See, the literature that are available in textbooks is usually 5 years old, because by the time the whole process of textbook research and production and publication happens, the literature that is quoted there will be 5 years old. So, whilst students have to be encouraged to read the textbooks as fundamental basic principles which will usually not change, and to know what is currently accepted in the textbook, but they also have to be encouraged to read journals, because that will give you the latest changes that have happened in the field of surgery. And to do this, critical appraisal is extremely important, and Nishant will highlight that. Other thing is, whenever we read journals, we come across multiple statistics. These statistics, I think, is a bugbear to all of us, and we don't need to get scared about it. Statistics, every news statistical method that appears in the journal, and now we have the literature and the knowledge at the press of a button on our mobile phones and laptops. So go through these statistical methods every time you see something new, and as you do that 3 or 4 times, you will get a hang of it. We don't have to become absolutely fantastic statisticians, but we should be able to decipher whether the current applied statistical method is appropriate for this particular paper, and also have a basic knowledge about what statistics to apply for what situation. So this is basically what it is. And journal club actually helps in actually improving our scientific temper, ability to critically analyze the data that is available. So what will happen in this today's session is, Nishant, who is a consultant surgeon at Shanthi Hospital and also Rashtrotana Parishad Hospital. He is a MS from KMC Hubli, and subsequently he is working with Dr. Lakshman, whom you all know very well. He is now a consultant surgeon in his own right. He won the prestigious KSCASI Mahadevan Award for his work on the audit of operating notes. He also won the National Best Paper Award in the National Conference in the year 2021. So Nishant is a very promising young surgeon with the eye to detail, and also with good research credentials. Dr. Niranjan is, I'm proud to say, is our consultant surgeon at Sagar Hospital. He is also, I'm proud to say, is my student who has come up so well. He is also a very good surgeon and a very good teacher with a good research credential as well. And he won the Millennium Gold Medal in the Bengaluru Surgical Society's annual award for the year 2018, where he presented his work on the use of gastrografin in the management of intestinal obstruction. So with this small introduction to these two young surgeons who are very, very talented and extremely knowledgeable, and Nishant is going to start off with the talk on what is the need for journal club, and then Niranjan will give you a brief, outlook as to how to conduct a journal club. And the next 30 minutes after that, we will have a mock journal club as to how it is actually conducted. Though there are many ways of conducting journal clubs, this method we find is internationally accepted and well received. Over to you, Nishant. Thank you.
Good evening, everyone. So thank you so much for the kind words. I'll be sharing my screen now. At the outset, I would like to thank KSCASI and its office bearers for giving us this platform. Now, the first question is, why should we even read about all these articles and all? Like Sir has already highlighted, field of medicine is constantly evolving. So unless we adapt ourselves, we are going to get left behind. Now, just because I said that, it doesn't mean that as soon as a latest technology or something comes into the market, we start directly using it. That is where the role of evidence-based medicine or evidence-based surgery comes into picture. Now, evidence-based medicine itself has a definition, but I just want you to look at the lines which I have underlined. It basically means that you should have judicious use of this best evidence that is available. Just because robotic surgery is available doesn't mean you start doing robotic surgery for everything that you can. And the second thing is, if at all, and the second thing is you have to integrate it with your clinical expertise, the infrastructure and the backup that you have. For example, you might be the best person to do major resections and surgeries and stuff like that. But if you don't have an ICU backup, ICU setting, probably it's not fair for the patient for you to undertake such a huge task. So in short, this evidence-based surgery basically has three components. One of it is the best external evidence, which you are going to get from all these articles, your infrastructure and your clinical expertise on one hand, and the third component being what is it that the patient needs. Now, what was generally followed back probably about 3-4 decades back was that we would listen to all these senior surgeons or big shots who would basically give out their anecdotal experience saying this is the best technique and you should follow this. But unfortunately, there was no follow-up. Now, if you do a good follow-up, that is when it becomes a study. And that is what differentiates it from an anecdotal experience. Now, talking about studies, what sort of study should we even look at or read? Now, for that, you need to ask yourself two questions. First is, how recent is this study? Why should we even ask that question? Now, let's just travel 3 or 4 decades back where Bessani's repair was the gold standard surgery for hernia. So you can't pull up a paper from 30 years back which says Bessani's repair is the best and even try to do Bessani's repair at the current time. And second thing is, once you pick out that article, you should be able to tell whether it's a scientifically valid article. That is where the role of critical appraisal or critiquing an article comes into picture, which I will talk about in some time. Now, like Sir already highlighted, information in textbooks is very vital, especially to pass your exams, which is a must for all the postgraduate students. But if you're somebody who's looking to advance your technique or stuff like that, then you need to look at either the peer-reviewed journal articles or conference paper presentations. Now, conference paper presentation, I come in and I give out the latest technique that I'm doing. But the problem is I might not see some small mistakes in that. So that is where I need peer review to come into picture. So that is the reason we take a step back and look at the peer-reviewed journal articles. Now, coming to the second question, how do we know that the article is scientifically valid? That is where this role of critical appraisal comes into picture. Now, here it's very simple. All you have to do is follow 10 questions and you'll know whether the article is scientifically valid. Now, let's have a look at the definition. Like evidence-based medicine, this also has a definition. Again, I just want you to look at the points that are in bold. The idea of a critical appraisal is one, to know the validity of data, the completeness of reporting, the methodology of the study, what are the conclusions that they have drawn, and whether they are complying with the ethical standards. Now, let us see this with an example. I just picked out this article from online where they have compared laser versus open surgery for perianal conditions. Now, if you look at the abstract, they have said that the aim of the study was to look at the effectiveness of laser versus the open surgery. They chose 98 patients. That means 49 patients in each group, where they used laser for one, open surgery for another. If you look at the results, it says that in laser, the duration was less, the bleeding was less, the rate of infection was less. And finally, they've concluded saying laser surgery is better than the open surgery. Now, let's look at those 10 questions that I was talking about. First thing is the study question relevant? That means you're supposed to critique a paper which is relevant to your field of expertise. You can't you can't pick up let us say a pediatrics journal and try to critique that article. You need to do something that is relevant to your field of expertise. And for those who are planning to start a study, if you want to know how to find a relevant topic or a question, there are two criteria. One is the PICOT criteria. One is the FINER criteria. It's out of the scope of this talk, but I've just put it to people who are curious about it and want to read more about it. Second question is, does the study add anything new? Best example I can give you is Apache scoring, Ranson scoring. All possible scoring underneath the sun have been done for pancreatitis, and we are continuously doing it. I'm sure all of us would have got fed up looking at it. The only thing pending is probably doing IPL scoring for it. Now, it is not adding anything new to what we already know. So the whole idea is we're trying to evolve, correct? Now, just because I said this, it doesn't mean that you shouldn't repeat a study. Let us say a study is being done for the Western population, but that might not hold true for, let us say, our Indian population, because the characteristics of the population is different. So the same question or the same study can be done for a new cohort or for a new set of population. And the third one is, what is the type of research question asked? For that, we need to look at three aspects: the cohort, the intervention, and the outcome. In simple words, cohort means your study group. Let us say you want to do a study on benign prostatic hypertrophy. You need to have elderly male in that study. You can't take a young 20-year-old male into the study and use him as a study arm or a control arm. Coming to intervention, if you are comparing two interventions, it should always be compared against the gold standard. Like you can't do robotic cholecystectomy and tell robotic cholecystectomy is best as compared to open. No, it has to be compared against laparoscopy. So that means whichever is the gold standard, it should be compared to that. Lastly, outcome. The best example I can give you is chemotherapy drugs. We give the drug to a patient, 10 centimeter tumor shrinks to 5 centimeters. That is not sufficient. You need to know how long they survived. It doesn't matter whether the patient died in 6 months with a 10 centimeter tumor or a 5 centimeter tumor. The outcome is about survival at that point of time, whether the duration of survival increased or not. So these are the three things that you need to see. Now let's go back to our example. Now this is a relevant topic, something related to the general surgeon. Now, is the study the population? It is done for, is it adding something new? Sorry. So it is laser versus open. So it is something new. And if you look at the third question, the population was for perianal conditions. And they have a good methodology, they have good results, and the outcome they're looking at was pain, bleeding, and infection rate. So far, so good. So this study so far is pretty good. Now let's move on to the fourth question. Is the study design appropriate? Now here, only two things that you need to know. If you're doing an observational study, like the example what I gave you about pancreatitis, here you can do a retrospective study as well. Always the best is to do a prospective, but a retrospective study can be used. But if you are looking for effectiveness or the outcomes, basically an interventional study, then the gold standard is to do a randomized control trial or at least a prospective study. You can't do a retrospective study at that point of time. Now, looking at this, I've taken small clips of this article and put it up. So this is a prospective study which they have done, and they have compared it on 49 patients in group A and group B, basically for hemorrhoids, fissure, and fistula. So again, this is okay. It's a prospective study, so we can accept it. Next is this, what the sources of bias. Now there are two types of errors. One is, two types of bias that we need to look at. One is the random error, which can happen by chance. Second is your systematic bias. Especially here, you need to pay attention to confounding factors. Now, again, let's go back to this example. Look at their inclusion criteria. patients with hemorrhoid, fissure, and fistula. I ask you a simple question. Is a first degree hemorrhoid comparable to a thrombosed prolapsed hemorrhoid? It definitely can't in any sort. So if I do laser for a first degree hemorrhoid and do an open surgery for a thrombosed hemorrhoid and say laser is better, it cannot be accepted. Now in this study, nowhere has this been mentioned. Same thing with fistula and ano. You can have straight track, you can have a curved track, you can have a low fistula, a high fistula and ano. And what's more funny is even the fourth point. They say that they've even taken inflammatory bowel disease into consideration. That means a water can perineum with multiple fistulae. So can you do laser for a low fistula and ano with a straight track and compare it to a big surgery that you have done for a water can perineum? You can't. So this is where this study falls short. Now going ahead, these are probably not for this particular article, but if you're looking at randomized control trials and all, you need to see whether the original protocol was followed. Sometimes if they don't get the expected result, they might change the inclusion and exclusion criteria. That's something you need to look at. Next is the duration of follow-up. Simple example, if you're looking at recurrence after hernia surgery, you can't do a surgery with a 3-month follow-up or a 6-month follow-up. It has to be 2 years. Same thing if it is a recurrence after an oncological surgery. You need to have at least 5 to 10 years follow-up. You can't do a follow-up of 1 year and say, oh, my surgery is the best, the patient is disease-free. Next, does the study test the stated hypothesis? We start off with null hypothesis. I'm sure all of us know that. So either null hypothesis is proven or disproven. Next, there's something called post hoc analysis. This is nothing but your secondary outcome. Okay, I'm sure all of us know that primary outcome is our main research question, and the extra information that we get because of subgroup analysis is our secondary outcome. Now, what happens? Sometimes the main answer they'll not get, so they'll project the secondary outcome as the main answer. It is not wrong, but it's not the right thing to do. Okay, it's not something that is appreciated. And the last point about selective reporting. This is basically for trials and studies that are sponsored by the pharmaceutical company. For example, they bring out a drug to reduce the blood pressure of a patient. They'll say this drug A is better than drug B in reducing the BP, but they'll not talk to you about the complication. Is it causing gastritis? Is it causing some skin rashes? Is it causing diarrhea? They'll not tell you about the complication. So omission of truth. So that is something that you need to look at. That is what we call as selective reporting. So the paper should be very frank and tell you what their limitations are. And like Sir said, every paper should have good statistical analysis that has been performed. So were there adequate numbers? Was the proper test applied? A simple example that I can give you. I have scored 48 marks. My friend has scored 49. Does that mean that he's better than me? No, it could have happened by chance. But if he does this consistently over 100 tests and he persistently outperforms me, only then we'll be able to tell that, yes, he is definitely better than me. Okay, so you need to have adequate numbers for you to come to a conclusion. So all the studies must have a p-value. They should have defined the confidence intervals. Now, if you look at this particular study I was talking about, they have put nice tables where they have looked at the rate of bleeding and they said the bleeding is less in laser. They have spoken about infection. They have said the rate of infection is less in laser. They've spoken about healing and they said the healing is faster in laser surgeries. But nowhere have they done a single statistical test. There is no mention about the test use. There is no mention about the p-value. And the last but one point is that do the data justify the conclusions? So your conclusion must be based on your data. Now let's look at the conclusions given in this study. First point they said is duration of surgery is important because it helps decreasing the exposure to anesthesia. At the outset, it looks like a very good sentence. Yes, duration of surgery is related to duration of anesthesia. Simple example, all of these cases are being done under spinal anesthesia. So where does duration of anesthesia come into picture? Just because he's got one finding, he's implied that the other one can happen, which is not right. Look at the third point. He says post-operative pain is less. That's why the need for post-operative analgesia is less. Again, I give you an example. A patient with a VAS score, that is a visual analog score of 2 in, let us say, laser, and a VAS score of 4 in open surgery. Now, for both the patients, I might be giving only one diclofenac tablet and both of them are comfortable with it. So where is the role of decreased post-operative analgesia? First of all, they should have had a standard pain protocol. That means everyone should get the same painkiller. I can't give paracetamol to one and morphine to the other. So this study, they've not mentioned that. And the last one is they said the decreased post-operative infection rate will help the patient get back to work early. Now, if I'm a lazy fellow, even if you do laser to me, you give me $100, $1,000, 1 lakh, whatever it is, I might not get up and go back to work. That has nothing to do with infection. So just because you've got one answer, you can't imply that the other one automatically gets applied. And finally, if there are any conflicts of interest, like I told you, the pharmacy-sponsored trials or drugs, they have to mention this was funded by so and so. Now, if it is funded, you have to be very careful. And like I said, look for post-hoc analysis and selective reporting. So far, you've seen the abstract and you've seen the entire article, or at least glimpses of it. I'm sure all of us have had this experience. We go to a restaurant and in the menu card, the burger looks extremely yummy and juicy and big. But what you get in the box is eventually just basically 2 buns with probably a little bit of cheese in between. Same thing is applied when you see a movie with a very good trailer and you go into the movie and you realize trailer was the only good part about the entire movie. Please apply the same concept to reading an abstract and reading the entire paper. Okay, the abstract might look very good, but the paper might be very short and but the paper might be completely misleading. So with that, I conclude and I hand it over to Dr. Niranjan, and who will take you through the steps of how exactly to conduct a journal club. Thank you so much.
So, good evening, everyone. Thank you, Nishant. That was an excellent appraisal of how to critically appraise a paper. So, in what is journal club? It is basically what Nishant told till now, where we practically apply that knowledge and is basically designed to critically appraise a paper. And also where we incisively can analyze our own practice and compare it to the world standards. And also it will help us in designing our own protocols and design our own studies. So go to the next. So it's basically a group activity and also it's an important conventional teaching tool. And in this group activity, there are various representatives. One is a moderator, where the moderator supervises the presenter, who will be invariably a postgraduate student, and he helps the presenter in choosing the article, and also he checks the presentation and also gives his inputs to critique the paper. So the presenter basically chooses the article, shortlist few articles, and in combination with the moderator, the presenter will choose one particular article, and the presenter will send that article well in advance, preferably at least a week in advance. And the presenter will also critically appraise the article and also prepare the presentations. They will also do a collateral reading where they will assess whether whatever the knowledge they have presented in this particular paper, is it the standard of practice or is it a new experiment, or what is the evidence on behalf of that particular intervention or a drug in the literature, and also gives us that this thing. So what is the role of the participants? They also read and come, where the journal will be presented to them in advance by the presenter, and they will independently also do collateral reading, and they will critique the presentation in the end. So how do you choose an article? The article should be preferably less than 2 years old, but not more than 5 years old, because by that time, as Nishant was telling earlier, textbook knowledge will be 5 years old. So the current knowledge will be preferably less than 2 and not more than 5. And it should be preferably from an index journal with a good impact factor. So what is that impact factor? Impact factor is where we assess the validity or an impact of a particular journal. And how do you assess the impact factor is you divide the total number of times its articles were cited during those 2 years, divided by the total number of citable articles published in the journal during those 2 years. So it's a journal's impact factor for that particular year is delivered like this, and it's one of the important assessments where you assess the impact of that particular journal. So JAMA Surgery and International Journal of Surgery are the 2 of the journals which have the highest impact factor. Our own Indian Journal of Surgery sadly is at the bottom. Its impact factor is around 0.4. And we should encourage our publications to be published in Indian Journal of Surgery so that its impact factor goes up. There is a new score which has come into vogue, which is also called a site score, which is again assesses the impact of that particular journal. The difference between the site score and impact factor is site score is based on the Scopus database, whereas impact factor is based on the Web of Science database. Citations from the last 4 years are assessed in site score, and citations of last 2 years are assessed in impact factor. And one more difference is in the site score, we take care where the articles, we take care of the articles, the journals, peer articles, and the original articles. Whereas in site score, it is in impact factor. You assess only the articles and the meta-analysis and systematic reviews. Whereas in impact site score, you assess the letter to editor, along with the articles and meta-analysis. So generally, the topic should be a clinically relevant topic which impacts on the current practice. It should be a original study. It should be preferably be an RCT if available, or a large cohort study. Case series, case reports, and retrospective studies and review articles should be avoided. But if you want to teach a proper critical analysis of a paper, sometimes you can use a retrospective analysis as well. So there are various types of studies. Basically, they are divided into descriptive studies and evaluative studies. Case reports are a series of few studies which are published as case reports. In case series, it can be around 10 to 20 of cases of one particular intervention, and then it will be published. Cohort studies, again, it is based on a few hundred number of interventions done, or few hundred number of drugs put into intervention. So evaluative studies are basically randomized control studies which have more value to a particular scientific paper. So there are two types of literature based on outcomes which we'll be studying. One is the primary literature, and then there is a secondary literature. Primary literature is basically published, it gives us the information based on one's own publication or original studies. Whereas the secondary literature takes out the information from this primary literature and presents us. So in the secondary literature, there are different types of literature. Sometimes it can be better than primary literature. Whereas, like example is systematic reviews and meta-analysis, where they critically analyze all those RCTs and also the original articles. And sometimes in meta-analysis, they also can alter the original statistics which are published in those articles, and then they can publish their own statistics. So the difference between meta-analysis and systematic reviews are that in systematic reviews, the statistics will not be changed. In meta-analysis, statistics will be changed. So there is some other literature called as critically appraised topics. Like example is up to date, where you can get relevant and up to date, like recent information on whichever topic you want to choose. There are various other important secondary literature like practice guidelines or consensus development reports, which can also deliver vital secondary literature. So how do you prepare the presentation? So the presenter will briefly describe the source, relevance of the subject, and research question asked in that particular paper. They will also describe each section with gaps between the sections. Like the sections can be materials and methods, results, statistics, and conclusions. The gaps is to ask the audience about how to critique the paper, and then the presenter will show his own critique. One. So the critique should not only about the bad aspects of the study. It is vital to assess the good aspects of the study, and also we should also touch on ethical aspects and conflict of interest, which Nishant mentioned in this previous talk. So there should also be a section on collateral reading, where the presenter will critically study the other relevant topics which are related to the present study, and also whether the results which are shown in this present study matches the world standards, like comparing the results of the two studies. And final question which will be asked at the end of the journal club is, can we apply this results to our own patients, or our own, can we change our practice based on this particular study? So in that we will study whether our patients can be similar to the same study group. Was the outcome which was presented in this particular journal was relevant, and also whether our skill sets are similar, whether we can change our skill sets, or whether we can change our practice. So we would like to acknowledge Dr. Lakshman and Dr. Ramkrishna, from whose data we have taken this information. We can also look into this data, which is freely available in our own website, kscsi.com. And also there are a number of videos which are published in the YouTube channel. Thank you. So from here on, now we will move on to a mock journal club where Nishant will present, and I would like to ask Dr. Ravishankar sir also to moderate the journal club.
So I think just like what using the information provided by Nishant and Niranjan, we will now conduct a journal club, which, as I said, is one way of doing it. But internationally, wherever we have been, and I think what Dr. Lakshman has been, and by knowing how journal clubs are conducted internationally and in many of the institutions in India, this is one of the ones which work well. It serves the purpose with which it is started out. So Niranjan will present this. This Nishant will present this
Nishant will
paper,
present.
and Niranjan will then conduct the journal club. And in between, I think this is the time for all the participants to kindly put up your questions in the chat box, and we will try and answer all the questions. Over to you, Nishant.
Can I start, sir, or do you want
Yeah.
are there any questions, sir?
There are, I think, as of now, there are no questions in the chat
Questions,
box.
I think we will take it up later, or shall we take it up in the end, or no?
There is one. Nishant, before you start, there is one question in the chat box. Which year PG should take up journal club? I think
Sir, there is no particular guideline to say which year PG should take up. I think it should start from the first year itself, where they can try to learn it from the first year itself.
You are right. I think the moderator comes in a big way in this. If the journal club is of relatively simple topic, you assign it to a first year PG, because they would not have known the nuances of surgery and things.
Yes.
So their comprehension of the depth of the topic will be less. So if the topic is a bit more complex topic, involving surgical technique and things, you should better give it to a second or a third year student who would have spent more time in surgery. So it is moderator comes into play. So whenever a first year student is doing a journal club, give them simpler topics, and the final year student you give a bit more complex topic.
Dr. Ravishankar, 1 second. Martin,
Yes,
kindly mute everybody, and all your voices are not very clear. I think so. Please increase the volume or do something on that. No, Dr. Nishant was heard, but Niranjan, your voice was very low. And Ravishankar sir, please increase your voice also, or come closer to the mic.
Okay, sir. Okay. Can you hear me better now, sir?
Yeah, better.
Yeah.
Am I audible, sir? Better?
Yeah. Sure.
Okay, over to Nishant now to start the journal club.
This article was actually shared on WhatsApp. I'm not sure how many of you have read it, but the idea is if you read it and come, we just give you the snippets here so that it becomes easy for you to understand what we're presenting. Now, this is a journal club that was already conducted by the Sagar surgery department, and I'd like to extend my sincere thanks to Dr. Nikita. So I basically just took her entire presentation as it is and I've come here. Only difference is I am presenting instead of her. So this is the article that, this is the PPT that she had presented. Now, the title of the article is The Prevention of Incisional Hernia with Prophylactic Onlay versus Sublay. Just give me 1 second. Yeah. Prophylactic onlay and sublay mesh reinforcement versus primary suture only in midline laparotomies. These basically, it's a long-term outcome of a multi-centric double-blind randomized control trial. Now, this was published in the Lancet. Now, the impact factor of this particular journal over a 5-year period was 20.9, which is astonishing and high. And even its side score is pretty high, that's 14.6. And this particular article was published in the journal in 2024. So it's a recent article. The incisional hernia is a frequent complication after abdominal surgeries and seen in about 15% of the overall population after undergoing laparotomy. They noted that patients with high BMI and abdominal aortic aneurysm have an increased risk of developing incisional hernia by almost 40%. The aim of the study was to assess the incisional hernia rate after extended follow-up of a randomized control trial that was already performed in the past. And there they had compared the prophylactic onlay mesh, prophylactic sublay mesh, and a primary suture closure of a midline laparotomy. And the name of that trial, which was conducted in the past, was the PRIMA trial. Now, this, like I told you, was a previously conducted randomized control trial called as the PRIMA trial. Now, what they did here is between March 2009 to December 2012, 11 centers from 3 different countries, that is Austria, Germany, and Netherlands, took part in this trial. They had randomized the patients from different surgical specialties such as the vascular surgery, gastrointestinal surgery, hepatobiliary, pancreatic, urological, gynecological, and then they took all these cases and then they compared the risk of incisional hernia between a primary suture, that is a large bite primary suture, versus onlay mesh and a sublay mesh for elective midline laparotomies. So this is the article which was the first study that was conducted between 2009 and 2012. Randomization was stratified by the center and also the indication of the surgery. The inclusion criteria were patients with a BMI of 27 kg per meter square or higher, or patients with abdominal aortic aneurysm as the primary diagnosis. They excluded patients where they underwent an emergency procedure or who already had an incisional hernia in the past, or if they were included in any other trial, or if they had undergone immunosuppression therapy within 2 weeks prior to the surgery, or if the patient was pregnant. Now, for this current study, that means the journal or the article that we're talking about, what they did is they went back and looked at the medical records of all the patients who were included in the first study, that is the PRIMA trial. And then retrospectively, they went through all their data and then screened them for this particular study. Now, amongst all those patients, those who were alive and who had no prior diagnosis of incisional hernia between this duration of 2012 to 2019, these people were contacted by the local investigators and then they were called to the OPD where they did a physical examination, they took a good history, and they even did a ultrasound of the abdomen. Now, all the data was analyzed according to the intention to treat principle. The comparisons between the primary suture, onlay mesh, and sublay mesh were made, leading to a pairwise comparison at an alpha of 0.017 according to the Bonferroni's correction for multiple testing. Now, this was in concordance with the initial or the PRIMA trial, since both the treatment arms were investigated.
So I would request the postgraduates first and the seniors later to critique the paper. If no postgraduates are forthcoming, I'll take some names. Praveen? Praveen is there?
Yes, sir. Yes, sir. Yes, sir.
Yes. Yes, Praveen, your critique.
Sir, this is a recent study paper,
Good.
and it was taken from a leading journal that is with a good impact factor.
Yes, and good side score as well.
Good side score, and they have it is an randomized control trial with a multi-centric study.
Good.
And it's a relevant topic. This recent.
Correct, current and relevant topic. Yes.
And,
anything else? Nikita?
Yes, sir. They have redefined the inclusion criteria, sir.
Okay, so which is good or bad?
Which is good, sir. I mean, like they specified the risk factors and they.
Correct.
And they went with a new protocol of following up the patients.
Okay.
With not just the clinical diagnosis, but also radiological, sir.
Correct.
Yes. Sir.
Anything bad?
Cons would be it being a multi-centric study, sir. So the data cannot be verified as good as a single center study, sir.
That is right, but not necessarily always.
Yes, sir.
Because if you can manage the data well, and since it is taken from a properly managed database, so it can be advantageous also with respect to numbers.
Correct.
Yes.
See, generally, for the knowledge of students, when a multi-center trial is conducted, that will be conducted with a set protocol and with all the study, researchers in combination with each other. There will be a data control center who will interact with the local data center on a regular basis to ensure that the data is collected appropriately, and also the secrecy and the privacy of the data is maintained, and a regular check of how the data progress is happening, and if there are any lacunae in the data collection, and that will be addressed. So I think if a properly conducted multi-center trial, as Niranjan said, has a lot of advantages, because if, for example, you are studying a rare condition, you may not have so many patients in your one center. So multi-center will give that advantage, so that you are studying a large cohort of patients. But the only thing is the protocol should be well set before, and all the study centers should follow the protocol to the last word. Okay.
So
Okay.
can we say gynecological patients were also taken, because this mesh repair which they have done, is it done by a gynecologist or a surgeon?
It was done by the gynecologists themselves.
Gynecologists
They did not
themselves.
get a separate surgeon. If it is a vascular surgeon who did the surgery, the vascular surgeon himself did either the primary closure, the onlay mesh, or the sublay mesh.
Then there is a high chance, technical wise, there can be a chance of.
Correct. There will
Surgeon
be.
factor.
Correct. Yes. If no other critiques, Nishant?
Yes, sir. Dr.
You can
Rajesh
show
sir
that.
has raised his hand. Can we
Okay.
take
If
his
I-
comment before
Only
we-
if this is a postgraduates, will critic in the end. I have no problems.
No,
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 sir.
no,
No,
sir.
sir.
No, it's open for
Please.
everyone.
Okay,
Okay.
right. No, just to continue the same thing, this all that was said as against, they have said it is for the paper, because they said multiple center means it reflects more on real life, right? And the point raised by the postgraduate saying that the gynecologist repaired the hernia, that they are saying is is the strength of the paper, because they're saying, this is what it reflects more of what will happen. You confine yourself to one expert center, the results may not be comparable, they're saying. And the only other thing is, this is a sponsored paper. This is sponsored by Brown. This is funded by Brown. Nobody's got that point, I think, the postgraduate.
Correct.
Yes.
And I think, for the benefit of postgraduates, they have followed the intention to treat principle, which is, I think, extremely important for a good research. Intention to treat principle means that the patients assigned to a particular group, irrespective of the change of status at a later date, will continue to remain in the initial assigned group, so that the data doesn't get skewed. For example,
Yes.
being, if you are comparing complications of laparoscopic versus open cholecystectomy, and if there are 4 patients from the laparoscopic group who get converted to open cholecystectomy for whatever reason, you still have to analyze those 4 patients as if they belong to the laparoscopic group, not the open group. That is the intention to treat principle. I think that is extremely important. Otherwise, the data will get skewed in the favor of
Yes,
one
sir.
or the other group. Okay,
Yes, sir.
Nishant.
Yes, sir. So coming to the pros of the paper, it's a recent study, but like we said, it's published in 2024, relevant topic to all of us. And it's from a journal which has a very good impact factor. And like sir said, multi-centric data means you get more numbers. Okay, practically it might not be able for you to find 500 cases of laparotomies in the same center. Now they had a good protocol for follow-up, and the best part was that it was a randomized controlled trial. Now we can't say bad of the study, it should be called as a con. First is the data collection was from secondary sources. That means for the second study, they went back into database, and then they had to exclude patients based on the data, whether they had had any incisional hernia or whether they were alive. So there's a chance that they could have missed out on patients for follow-up. And of course, please add on all the other points, whatever were highlighted by the postgraduates and the staff here. Now, moving on to results, the initial study of the PRIMA trial, 498 patients were enrolled, of which a few were excluded, and they had 480 patients. Now, by the end of that study, that is 2012, they had a follow-up of 341 patients, of which 62 underwent primary repair, 146 with the onlay repair, and 133 with the sublay repair. And these are the patients who didn't have any incisional hernia. Now, for the second study, only 10 of the 11 hospitals were willing to participate. However, they did get data for the 11th hospital as well. Now, for this current article, that is for the study between 2019 and 2022, out of the 341 who ended the first trial, they were able to contact only 255 patients, of which 47 were from the primary suture group, 104 from the onlay, 104 from the sublay. And of this 255, they were able to do an additional long term. That means not only that 3-year study, they were able to go beyond that for a further 142 patients. Now, the primary outcome was assessed in the overall population because they're looking at incidence of incisional hernia from the time of the first surgery. So they had to do it on all 480 patients. Now, their median follow-up was of 2 years, minimum of 15 days, that is half a month, and maximum of 138 months, which is 11.5 years. Now, the same thing, whatever I've told you, they've put it in a chart. This is called as a consort chart. So 498 patients were there, of which 480 included in the study, and they were divided into primary, onlay, and sublay. Now, continuation of the chart. Again, by the end of it, like we said, 350 remained, of which 62 were in the primary, 146 in the onlay, 133 in the sublay. And for this current study, that is between 2019 and 2022, they ended up with 250 patients. Now, the cumulative percentage of incisional hernia diagnosis at a 5-year follow-up was 50% of patients had an incisional hernia in the primary suture group, 24% in the onlay group, and about close to 30% in the sublay mesh group. Now, what is surprising is the result of the initial study. That is, at the end of 2 years, the incidence of hernia was only 30%, 13% and 18% respectively in these 3 groups. Now, you see that the rate of incisional hernia has been increasing even after those 2 years, as contrary to what we believe that the hernia happens only in the first 2 years, or the incidence is maximum. Now, the same thing is depicted in this chart. You can see that the incidence goes on peaking almost to about 3 years and then slightly plateaus, but there are still incidences of incisional hernia. So not only 2 years, even beyond 2 years, they found that the incidence of incisional hernias kept on increasing. Now, when they adjusted for the potential confounding factors, a significant hazard reduction was found for both the onlay mesh and the sublay mesh closure as compared to the primary suture. Now, there was deviations from the intended mesh group allocation. So this is that intention to treat analysis. After randomization, let us say some patient was in onlay or sublay. For some reason, the surgeon decided not to put a mesh, either dissection, infection, whatever it is. But they can't take them out of the group. They continue to persist in that group. Such a scenario happened in 45 patients, which is about 10%. And of those 45, 22 patients developed the incisional hernia. Now, secondary outcomes means they again looked at the incidence of incisional hernias in their 2 inclusion criteria. One is the BMI and the other was in patients with abdominal aortic aneurysm. And both of them showed a similar trend of increasing the rate of incisional hernia as the time progressed. Now, after the extended follow-up, 31 patients who had a recurrence or who had an incisional hernia actually underwent surgery, of which 7 were from primary suture group, 12 were from onlay group, and 12 were from the sublay group. Mesh explantation was performed in 48 patients, with redo surgery unrelated to the mesh being the most common reason. Now, the same thing has been depicted in this chart. You can see that mesh explantation overall, this is the number. And like they said, redo surgery, which is unrelated to the mesh, both put together was the most common reason. Now, I would like to invite Dr. Niranjan and Dr. Ravishankar back for the critique up till this part.
Yes, any of the postgraduates can start off.
I think people should please participate.
Come forward. Yeah, this is for them only.
Sir, the pros of this study is it is they have given in good diagrams, concert diagrams, and graphs, sir. And they have given
Yes.
tables, and they have analysis with
What is that?
good.
What is that? What is that? This thing, consort diagram.
Huh?
What is consort diagram? Vinod, you said good consort diagram. No, what is that consort diagram?
Sir, they have given. They have nicely in a graph way, such that in the how much people were involved and how much were in the primary in the suturing part, and how much in the sublines, how many people are in onlay. So in such a way, they have given nice consort diagrams.
So it's a typically used to depict participant flow information in journal publications. Okay. So yes. Then
Consort diagrams are mandatory in any paper, especially with the randomized control trials,
randomized RCTs.
because you need to account for all the patients that have been randomized, and if they have dropped out, loss of follow-up, and if they have been changed the protocol, everything has to be represented in the consort diagram. So if a good consort diagram will virtually give you how well the study has been conducted.
Yes, sir.
So what does that consort stand for? It
Sorry,
stands for, what does that consort stand for? What does it mean? Consort. Full form.
Sorry,
It
sir.
is
No.
it is Consolidated Standards of Reporting Trials. Okay.
Yes, sir.
Yeah. Move on. Then next. Good graphs and tables, you said. Then
statistics, sir.
Yeah, statistics are also good.
Yes, sir.
So anything else or cons? You want to talk about cons?
No, sir. I don't think.
Anyone else? Nikita?
Extended follow can be a pro point. They try to
Sorry?
the extended follow up that they try to do further beyond.
Correct. So that is the purpose of the study. Yeah, good.
Yes.
So the longer you analyze for an hernia, you will the numbers of the patients getting hernias will increase. So they have studied up to 10 years, which is good. Yeah.
So at this time, it is important for all the postgraduates to understand that when their results are tabulated, the statistical analysis applied, you will always see new statistical methods coming up in the paper. You please go through the the Google or whatever statistics and find out. For example, in this they have shown three things. One is the this one Kaplan-Meier survival. Second one is the Bonferroni correction, and third one is the Cox proportional hazards. So all the three are very relevant, and please, all of you should go through what each one means. As I said, we are not going to become excellent statisticians at the end of a journal club. Nor that is the purpose. The purpose is to understand what the particular statistical test is doing and has it been applied correctly. So over a period of time, as you keep doing this, you will understand how a statistical test is done and how whether it is relevant or not. Because if you use the wrong statistics, you can make a bad study into a good study, which happens many times. So this is why you should know whether the correct statistics has been applied to a particular data, so that you know that the data has not been fudged. The data, you can easily make the data appear better than it is, which is why the Bonferroni correction is there. So you should know how the statistics has been applied and whether the statistics is relevant in this particular case. So for this if you study the statistics that is available in the literature, you will be able to slowly get, for example, initially parametric data, non-parametric data, all these things, they are simple, mean, mode, and all these things. And then gradually the new tests like Wilcoxon test, Mann-Whitney test, Kaplan-Meier survival, proportional hazard, and then odds ratio. These things you will start understanding student t-test. So you will get to know how each test is applied, and you will slowly understand. So don't get flustered by new tests appearing. Just make an effort. Niranjan?
One more vital source of statistics is our own Dr. Ramakrishna sir's book.
Correct.
Yeah. Nishant?
Yes, sir. So
If no one else is critiquing, Nishant, I would like ask Nishant to.
If they mentioned that in the sub-lab and on-lab in the group, 22 patients were not given the mesh, can it be a concern? Because it might be intention to treat, but that will fuzz up the data.
Won't.
No, it won't. That is what sir was telling. No intention to treat principle.
Okay.
If you don't do that, then the surgeon will choose all easy cases for one and difficult cases for the other just to prove his point. So it has to remain in that particular group itself. So let's carry on. The pros was, like it's already mentioned, a good consort diagram, graphs, tables, everything was self-explanatory. Statistical analysis was already mentioned. The cons were they had a lot of patient lost to follow-up. Now, we can call it as a con, but at the same time, they're trying to achieve something that is a follow-up of 10 years for a hernia repair. So, which is not very easy. So, we can put it to con, but at the same time, we have to appreciate that they have put in the effort to do that. Now, moving on to discussion, the effectiveness of the onlay and sublay mesh in preventing incisional hernia has been demonstrated. The rate of incisional hernia in both the prophylactic groups kept increasing as the time passed. The rate of incisional hernia after the initial 2-year follow-up continued to increase, although majority of the events occurred within the first 3 years after surgery. Now, the finding of this study was also found in a study conducted by Berger et al. And another technical factor to be considered, please remember that this was a study conducted in 2009. Back then, the mesh overlap used was 3 centimeters, whereas now the standard is to have an overlap of 5 centimeters. Same thing with regard to the bites taken. Back then, it was 1 centimeter apart from each other. Now they say it is 0.5 centimeters away from the edge and 0.5 centimeters from the previous stitch. Now, they've gone on to state that the limitation was the number of patients that they lost to follow-up. The lower numbers at risk during long-term follow-up from 3 years onwards limits the accuracy of these estimates, and the protective effect of the prophylactic mesh might have decreased after these 3 years. Now, patients with incisional hernia may be more likely to participate in the study follow-up, causing selective loss to follow-up. And if true, this would mean the estimated incidence rates underestimate the true rates. So they go on to conclude that significantly fewer incisional hernias occurred in the prophylactic mesh groups as compared to the primary suture. Now, the incisional hernia in the suture group appeared to occur after a longer period of time and to higher rates than what was described in the past. Now, because of technical simplicity, onlay mesh placement could have been the preferred prophylactic mesh closure technique, because like we said, it was even a vascular surgeon, a gynecological surgeon, everyone who were operating. So not everyone might be comfortable enough to do a sublay repair where you have to perform a retrorectus dissection. Now, looking at other similar papers, this was from 2021. Again, here they go on to state that the prophylactic onlay mesh repair reduced the risk of incisional hernia as compared to the primary suture repair, but it had a higher seroma formation rate following surgery. Another one from 2018, again, this was a meta-analysis where it's a systematic review and a meta-analysis where 4 randomized controlled trials with a total of 388 patients were analyzed. And pooled analysis showed that mesh reinforcement significantly reduced the risk of incisional hernia after abdominal aortic aneurysm repair. Now, the question that we would all ask ourselves at the end of any journal club is, based on all the findings that we have learned from today, would you change your practice and would you try to use a prophylactic mesh after doing a laparotomy? Now, please keep it in mind, we have actually rushed through this entire article because it's a demo article and we have tried to finish it in about 15-20 minutes. But ideally, this is a class done over 1 hour. So I urge you all to please join our journal clubs, which is conducted by the Sagar Surgery Department. So it's a 1 hour thorough discussion about all the theoretical aspects, the statistics, and the methodology of the paper. Over to you, sir.
So I would welcome the audience to critique on this last bit of conclusion, as well as the final question. Would you change your practice based on these findings?
Hebsur, sir.
Dr. Ravishankar, yes, it was very well conducted, Dr. Ravishankar. Dr. Niranjan and Nishant. You people have really given a very good gist of how to conduct a journal. Plus, the journal demo was also superb. I think so. We need to see the why we conduct these journals is how we can improvise our practice and change to the times and improvise our ways of doing things also. And as the last slide showed, Nishant has pointed out, would you like to change the practice? Yes, I think so. Looking at the evidence-based medicine, we should practice rather than saying that anecdotal saying what I have been doing is the best. And we need to change according to the times and improvise ourselves. Why not implement this kind of sublay or on-lay mesh repair for primary abdominal closures? We should think about it. This is what is my take, I think so.
I think.
Dr. Siddesh sir and others.
Dr. Siddesh sir and Dr. Shanai after that. Dr. Siddesh sir.
Yeah. Good evening again. Thank you. I think that was a very well conducted educative program. My loss about today's program is the numbers. See, more than 50% are teachers here. So I hope this is a teaching session. This will be available on the net for other students to join in and learn from this such a wonderful effort which has been put forward by the Karnataka State Chapter, and all the faculty who have put in such a wonderful show should go useful for the vast majority of postgraduates whom this is aimed at. And I feel this is very well conducted and educative, how to critically evaluate a scientific paper. So that is the main aim. Of course, going by the value of the paper, if you want me to comment on the paper itself, I would say it's very premature. I cannot change the way I think the main issue would be to identify those high-risk group of surgeries, laparotomies, which has not been highlighted in this paper, which I think we need to get back in our domain of practice, which are those high-risk patients. If we can identify, definitely, we have used some sort of measure prophylactically to prevent hernias. So I think we have, of course, this is an eye-opener for such patients of high-risk patient group. If we can establish that particular group, definitely this would be a way forward, and thinking in this direction of using a prophylactic mesh, which I have not done in my practice as a routine. Maybe a couple of times where there were previously existing hernias on a patient whom I have done a laparotomy for not related to the hernia as such. So that may not be the real scenario what we are talking about, the prophylactic surgery or measures to do, technique to do prevention of hernias. So these are my takes, but I should really congratulate Ravishankar, Nishant, wonderful presentation, and Niranjan, really you have guided the postgraduates very well in the domain. I hope people will get gain to, I am a gainer here. Thank you.
Thank you very much, sir. Dr. Rajgopal Shanai, sir.
Thank you. Dr. Ravishankar and Nishant and Dr. Niranjan, wonderful work. And Hebsur also for the organizing all these events. Just to add one or two lines, that there was some mention about gynecologist and other things here. So what we should understand is after the Fallon steel, this lower midline has become relatively less, number one. And of course, laparoscopy is another thing, has given a big boost for all this hernia. So why I'm telling this, because in the linea alba is very thin there and no posterior rectus sheath. So it's no wonder that we should probably first target the change of the practice for the lower midline incisions rather than the upper midline. This is how probably if someone wants to try to change the, the ideas of the, probably this is what something which we can take. This is what is the small take from my side. Thank you. That's thank you.
Ballal sir, your take.
No, nothing. Just one more thing. What worries is they have included ASA grade 4 patients for elective hernia repair. That's a little worrying compared to ASA 1, though the numbers are fairly small. That's one point I think somebody needs to look at, but otherwise, nothing else, sir.
So would you change your practice?
Probably not. Maybe I'm not entirely convinced that you need a mesh for all patients.
Sir, if I may, their actually studied population was patients with high risk. Basically, for abdominal aortic aneurysm, they believe that they already had some sort of collagen vascular disease.
They'll be having high risk.
So only those were their target audience, population, rather than our routine midline laparotomies that we perform. Like Sidhe sir
That's
said,
exactly was my point when I spoke. Correct.
Yes, sir, that's what. Like Sidhe sir said, we have to identify those patients at high risk and then probably think of applying this knowledge.
Correct. Chandrashekar sir.
Yes, sir.
Your comments.
Yeah, I should congratulate, sir, Dr. Ravishankar, Nishant, and Niranjan for an excellent presentation. And actually, you showed us how you're going to do a journal club and how it should be done. Thank you very much, sir. It was a fantastic, informative session. And hopefully, the postgraduates and the postgraduate teachers who have attended will take a few points definitely out of this. One, and we cannot generalize everything. I mean, for all laparotomies, we cannot able to generalize and do, but definitely there is an indication for use of mesh when you do a laparotomy for wound closure. So we need to decide on case basis. That is one. Otherwise, it was a fantastic program, sir.
So I think in the end,
yes, sorry.
Yes, sir.
Second point. That's, the kind of a moment to keep a mesh, it takes a long time and all. But as rightly in the paper, just keeping an online will just add 10-12 minutes. This is something which is very, that point also to be stressed on our thank you.
In fact, I think so. If the article says it is only for the high risk patients, only these meshes have been used.
Yes, correct.
And it is not for routinely, isn't it, Nishant?
Yes, sir. Yeah. And Dr. Sangamesh asked a question whether critiquing is necessary. Of course, I think the purpose of journal club is to divide the journal club into 3 or 4 sections, and you critique each section so that you understand how each methodology, the results, statistics, conclusions, all of these things. Are they do they follow the set pattern or have they jumped the gun in any way? To conclude,
and also one more important point is just because that particular article is published in a well-reputed journal with a high impact factor, it doesn't mean that the data published there can be accurate.
Yeah.
It still can have lots of cons. So you should know how to critically appraise a paper, however good journal it might be published in.
So I think journal club critical appraisal has to become, I am stressing the word, it has to become a norm for all postgraduate students. You graduate from being a undergraduate to a postgraduate by learning how to critically appraise, and constantly change your outlook towards any particular thing. Change that happens, you should be based on sound principles and sound data. So please, all of you, develop this scientific approach, scientific etiquette, and learn to become not only good technical surgeons but also good researchers in a small way, just to appraise your own particular practice and compare it to the international standards that is happening. So that is the purpose of the journal club. I would urge all surgical departments to conduct journal club. It will improve the entire department without any doubt. Thank you very much for the
Ramakrishna sir has raised his
this
hand.
opportunity.
I think Dr. Ramakrishna wanted to tell something.
Ramakrishna, sorry. Ramakrishna, your views. Is Ramakrishna there?
So, sir is lost. Let me say,
can you hear me,
Dr.
sir?
Ravishankar, sir, it was very well conducted.
Yes, sir.
Hello.
Yes, sir. I think
Dr. Ramakrishna, sir, please speak.
Can you hear me, sir?
Yes,
yes, sir.
Yeah. Dr. Nishant and Niranjan have conducted this very well. And this is almost a flawless paper. Even after giving so much data, if we don't change our practice, there is no point in studying any paper, sir. I think with this data, we should be able to change our practice. And high risk, they have very clearly defined BMI more than 27 and abdominal aortic aneurysm. That probably we don't get many patients, but definitely BMI more than 27 we get in our routine practice. Whenever we are using midline incision, we have to change our practice, put a mesh. That is the take-home message of this article, sir. I think there is only one confounding variable I found was They have not studied upper midline and lower midline separately because the incidence of hernia may be different for these two. Other than that, it is almost a perfect paper with lot of very good data. And because patients are lost for follow-up and so many censoring is there, that's why they have used KM plot. Otherwise, they would have used chi-square test to show the level of significance. So many patients they used to get, it's like survival analysis in cancer. Like that, they have analyzed. That's why they have used the KM plot. It is an excellent method. And I think we have to change our practice for doing surgery on BMI more than 27.
Thank you, sir. Dr. Ramakrishna, sir. Dr. Ravishankar, Dr. Nishant, and Niranjan, you've done
Thank
a
you, sir.
very excellent job. Thanks for again doing the journal. This is, I think, so last year also you've done the similar journal. There also it was something unique and very good. That's why we chose the same team. And this team, I don't think so anybody can duplicate also. It's a beautiful team what you are working. And wonderful. Thank you so much. I request Chandrashekar to please present the vote of thanks so that we can conclude.
No more questions. We conclude the session. Behalf of KSCASI, Shani sir, you want to talk?
No.
No. Behalf of KSCASI, I would like to extend my sincere thanks to the moderator of this session, Dr. Ravishankar, the speakers, Dr. Nishant and Dr. Niranjan for an excellent informative talk. And behalf of KSCASI, I would like to thank our past national president, Dr. G. Siddesh sir, who has attended today's webinar. I also thank all our national and state EC members and all the members of KSCASI, postgraduate students and the members for attending this webinar. Thank you, everyone. Thank you very much.